All right, we are talking about anti-diabetic drugs. The first thing we're going to talk about is the pathophysiology of diabetes. So hopefully you've looked at the diagram video recording already, so that this is just review. So insulin is made by the beta cells in the pancreas. The insulin facilitates transport of glucose inside the cell, and this can be a skeletal muscle cell, a cardiac muscle cell, or adipose tissue. It provides energy for the cells. It facilitates liver to store glucose as glycogen, so there's glucose storage inside the liver. It also promotes potassium and magnesium to stay inside the cell, which will temporarily result in hypokalemia and hypomagnesemia levels. It is a disorder of carbohydrate metabolism. In type 1, there's a deficiency of insulin. There's just not enough insulin to open up the receptors. And in type 2, there's resistance of the tissue to insulin. So basically the receptors don't respond to insulin. There's either a defect in the insulin receptors that are in the liver or on the skeletal muscle or the adipose tissue. A diagnosis of diabetes is generally with labs. The fasting glucose will be greater than 126 milligrams per deciliter according to the 2015 ADA recommendations. Your fasting glucose should be between 70 and 130. Your hemoglobin A1C will be greater than 6.5%. According to the ADA, it should be less than 7%. Glucose in red blood cells is what this detects. So when the glucose is taken up by the red blood cell, the glucose stays for the lifespan of the red blood cell. So that's approximately 120 days. So that's why the hemoglobin A1C will tell us basically how the glucose levels have been the past few months, because it's how long the red blood cell has been hanging out. You also have an estimated average glucose. This basically takes the A1C and converts it into a glucose level. So, for instance, an A1C of 7% corresponds to an EAG, or an estimated average glucose, of 154 milligrams per deciliter. It's something they're thinking about changing, because changing from using A1Cs to using EAGs, because patients seem to better understand EAGs. They understand that a 154 is not good, it's too high, whereas a hemoglobin A1C of 8, they don't really get it that much. There are also signs and symptoms of hyperglycemia. You absolutely need to know these. A fasting glucose of 126 or greater, they're going to have polyuria. Why do they have polyuria? Because they have increased urinary output because of the osmotic diuresis from the increased sugar concentration in their urine. Okay, that's just going to draw in lots of fluid. They have polydipsia, which is increased thirst. Because you have increased urinary output, you're basically dehydrating yourself, so you're really thirsty. Then you have polyphagia, which is increased appetite or hunger, because the cells are not getting glucose, so they think they're starving. So they're telling you, hey, we need some food. You need to give us food because we have no energy. You're going to have glucose in your urine because the renal tubules are overwhelmed by the amount of glucose that they're having to reuptake back into the bloodstream. In your kidneys, you have, so if you think of your kidneys as a giant strainer, so your glomeruli, they bring blood into your kidneys, and this blood is filtered through your renal tubules. So if you just imagine this bowl is a strainer, every hole that's in that strainer has a straw attached to it, and that's your renal tubules. So it goes through your renal tubules, and at your renal tubules is where it's decided that it is either going to go out in urine or is it going to go back into the blood. And usually at the renal tubules, all of the glucose is taken back into the blood. None of it goes out in the urine. So when you start to see glucose in your urine, you know that the renal tubules are overwhelmed. They can't reuptake all that back into the blood, and so you have spilling of your glucose into your urine. You're going to have weight loss and blurred vision. The reason for this is no glucose is getting into the cells. So the cells start doing anaerobic metabolism, which is breaking down carbohydrates, which makes you lose weight. There's fatigue because the cells are not getting enough energy. They're not getting any glucose, so there's no energy there, so they're very tired. Complications of hyperglycemia, this is what we're trying to avoid with these diabetic medications, is that the increased glucose inside the intravascular space actually causes an inflammatory response within the intravascular space. This inflammatory response actually acts as a magnet for lipids and for cholesterol to collect on the sides, and so it creates or it expedites atherosclerosis. Okay, so you get macrovascular complications, you're going to get microvascular complications because it's clogging up the vascularity quicker than it normally would because of the high glucose levels, causing that inflammatory response. So even at a fasting glucose of just 126, the lowest that they consider a diagnosis of diabetes, is going to start causing that inflammatory response. So that's why it's so important that we keep our glucose levels below 126 because of those complications. So type 1 diabetes, the etiology, well, basically there is a genetic predisposition. So we will want to ask about family history. There's an increased risk if it is in their family. They say it's triggered by a major stress, and this major stress can be physical or it can be mental. The pathophysiology behind it, basically it's an autoimmune destruction of the beta cells. They believe it's potentially a virus because viruses, how they work, is they're little proteins that get inside our cells, and they kind of take our cells hostage, and they start making virus factories out of our cells. And so that cell will create a lot of virus, and then it will burst, and those viruses go off and invade other cells within our body. So our body's response to that, our immune response to viruses, is that these cells that have virus within them, is they put up like an antenna that says, hey, I have a virus in me, come eat me. And so it kind of basically tells our immune system, hey, eat me, which is a normal body cell, because I'm infected. So the thought is that when the immune system starts eating these cells that have these antennae on them, they don't stop at just the ones that have this antenna that says, hey, I have a virus. They just keep eating away all these cells that are the same kind of cell, and thus causing an autoimmune disease. So that's what the thought is that it's a virus that spreads it. But it results in a complete lack of insulin production. So your clinical manifestations are acute hyperglycemia, and the treatment is to give insulin because we don't have it. You're not making it, so we need to have it. Type 2 diabetes etiology, they're unsure, but there is an increased risk with obesity and with a family history. The pathophysiology, you have decreased sensitivity and responsiveness to the insulin, which leads to a decreased number of receptors. Because of the decreased responsiveness, the body thinks it doesn't need the receptors since they aren't being used. So this increases the amount of insulin hanging out in the blood, which then leads to decreased insulin production because the pancreas thinks there's enough there, so it doesn't need to produce anymore. And then the beta cells have decreased responsiveness to the increased glucose levels. So Lewis will say that it causes a temporary increase in insulin production at first, but then the insulin production will decrease over time. So eventually you have a decrease in insulin production, and that's when you have type 2 diabetics who need insulin instead of these other medications that we're going to talk about. So your clinical manifestations, they have impaired postprandial glucose metabolism, which means after meals. So generally there's a spike in glucose after you eat, after meals, and the body is not responding properly to it. So the liver should be taking up that extra glucose and making, and storing it, but it doesn't do that well. And then insulin doesn't open up the receptors. So all of that results in hyperglycemia. So you have a lot of glucose that's hanging out in the body. Treatment is to make we can either make the receptors more sensitive to insulin, make them respond better, or we can decrease the amount of glucose that's secreted or produced by the liver or absorbed by the intestines. And so those are the things that we're going to talk about when we talk about type 2 diabetes. So insulin. Indications, type 1 is absolutely required because your body's not making it anymore. With type 2, we talked about how if there's no response, if the decrease in the response of the receptors comes back to having a lot of insulin that's hanging out in the blood, the beta cells stop producing the insulin because there's so much insulin hanging out, and so they start to have a decrease in insulin production, and then they'll need it for type 2. So only anti-diabetic med recommended for pregnant women is insulin. It's administered sub-Q injection. These can be insulin syringe or a pre-filled pen. There are also insulin pumps, which provide 24-hour administration, and then boluses if needed. Dosages are in the number of units per ml. So when you see a U100, that means there's 100 units of insulin in 1 milliliter. And U500 is a high alert drug, which means there's 500 units of insulin in 1 ml. So you could see where that could cause some medication errors, and so a lot of hospitals will not use the U500. Mechanism of action, it provides the function of insulin, right? We're replacing insulin because our body's not producing it. So it promotes cellular uptake of glucose, all the things that insulin usually does. So it provides the key for glucose to get inside the cell. It facilitates conversion of glucose into glycogen in the liver. It moves potassium inside the cells with glucose temporarily and can be used in the treatment of hyperkalemia while awaiting like oral potassium binding medications like, say, Kxalate. So the adverse effects could be hypoglycemia, which is a glucose less than 70. An abrupt hypoglycemia, signs and symptoms are the tachycardia, palpitations, diaphoresis, shakiness. Gradual hypoglycemia side effects are headache, tremors, weakness, lethargy, and disorientation. It can cause lipohypertrophy, which is accumulation of extra fat at the site of a sub-Q injection. You want to instruct patients to rotate their sites. It will go away eventually if the site's not used, for a while. That area is not as effective at delivering meds anyway, so you don't really want to give meds in these areas if they have lipohypertrophy. Contraindications, hypoglycemia. So we always want to check our blood sugar prior to administration. Interactions, it can increase hypoglycemic effects. Those meds are sulfonylureas, meglitinides, which are both oral anti-diabetic meds, beta blockers, and alcohol. Beta blockers actually mask the signs of hypoglycemia, and alcohol, actually you can not realize that you're getting hypoglycemic, because many of the signs of being inebriated are also the signs of hypoglycemia. It's interesting because alcohol, over time, excessive alcohol consumption can cause a decrease in insulin effectiveness. But just alcohol consumption can cause hypoglycemia because the liver spends its time removing alcohol instead of managing the blood sugar. So it won't respond to the low blood sugar levels because it's already working, spending all its time trying to get the alcohol out of its system. So medications that can counteract the effects of insulin, which means that they're going to cause an increased glucose level, those would be like your thiazide diuretics and your glucocorticoids, which, are steroids. Beta blockers, we already talked about, can mask the signs and symptoms of hypoglycemia. So we want to monitor glucose closely because they can't rely on just signs and symptoms if they're on beta blockers. So they really need to be checking their blood sugars more often. So nursing considerations, we want to monitor for hypoglycemia or hyperglycemia. Make sure that you know the signs and symptoms of both of these. You're going to increase risk for hyperglycemia during stress, either emotional stress or physical stress. You always want to double check your order with another nurse. There has to be a witness. You always want to draw it up in the vision of the other nurse. You want to draw it up with them present, okay? And you don't want to co-sign somebody when you didn't see them actually physically draw up the insulin, okay? Could be anything in there. You don't want to shake the insulin. You have to roll it between your hands to mix it before drawing up the dose. Or if they're using an insulin pen, you're going to roll the pen before administering the dose. So insulin storage, you want to administer it at room temperature. You want to store at room temperature if you're going to use it within 1 month. If it's going to be longer, you're going to refrigerate. Then you always refrigerate unopened vials until the expiration date. Use only insulin syringes. These are orange caps. They're calibrated in units, so they'll say either 100 units per ml or 500 units per ml on them. They have a pre-attached needle that's 29 gauge, 1/2 inch. When you're mixing insulins, you're always going to mix clear, then cloudy, or draw up the clear one and then the cloudy one. So you're going to put air in the intermediate acting, which is the cloudy, and then you're going to put air in the regular or rapid acting, which is the clear one. Then you're going to draw up the regular acting or clear one, and then you're going to draw up the cloudy one, which will be the intermediate acting one. So next are just some pictures. Here is the insulin syringe I talked about. It already comes with the needle attached. Here is the insulin pen. This, you twist it to dial in the units. You roll this just like you would any of these vials down here to mix them up, to mix up the insulin for the insulin pen. Now, if you can see sort of on this slide, the regular insulin is clear. This is mixed insulin right here, and it's slightly cloudy because it has some intermediate insulin in it and has some rapid acting or fast acting in it. And then the last one is cloudy because it's an intermediate acting insulin. So your nursing considerations, you want to give the sub-Q at a 90-degree angle unless they're emaciated, and then you can give it at a 45-degree angle. Make sure the patient is tolerating food. You don't want to give them insulin if they're not getting glucose in their system. Okay, you're going to have their glucose drop drastically. Also make sure that the meal trays have arrived on the unit before you administer the insulin. If signs and symptoms of hypoglycemia occurs and it's a conscious patient, we're going to have them eat or drink 15 grams of quick-acting carbohydrate, which would be about 4 to 6 ounces of regular soda, 5 to 8 lifesavers, 1 tablespoon of syrup or honey, or 4 to 6 ounces of orange juice or dextrose products. They should have these on hand at all times in case their blood sugar gets low. They need to, after they administer one of those, they need to wait 15 minutes and then check blood sugar again. If it's still less than 70, they need to repeat the process. Eat or drink one of those things. Once the glucose is stable, if the next meal is an hour away, then they need to give, or more, then they need to give more carbohydrate plus a protein to help sustain them until their next meal. If it's an unconscious patient, we're going to give sub-Q or IM glucagon, or we're going to give IV D50, which is 50% dextrose. So patient teaching, they always need to wear a medical bracelet, provide instructions and a demonstration related to the administration of the insulin. You want to educate the need for frequent monitoring of glucose levels and A1C, because we need to monitor whether it's effective or not, okay, if what we're giving them is effective. We need to stress the importance of exercise, foot care, dietary plan, and weight control. They need a consistent carb diet to decrease the fluctuations in glucose levels. They also need to have a planned regular exercise as well. They need a journal that would include their diet, their glucose levels, and basically how they're feeling. Information related to anticipated cost is extremely expensive. It's about $12,000 a year for diabetic supplies. You need to discuss signs and symptoms of hypo and hyperglycemia and what to do if they occur. They need to definitely be keeping quick dosage forms of glucose in possession at all times in case they get hypoglycemic. Hypoglycemic is much more detrimental than hyperglycemia is. We discuss situations that lead to altered serum glucose levels, just so that they're aware and that they can monitor themselves more closely. Examples would be like physical or emotional stress, anorexia, so they're just not eating, if they increase their exercise for whatever reason, and alcohol use is definitely going to affect their glucose levels. They always need to take glucose before taking insulin, so they need to be eating, okay? They need to rotate sites of sub-Q injection, allowing 1 inch between injection sites. This will help prevent lipohypertrophy. And then proper storage of insulin, how they need to store it. So there are a few types of insulin, 4 actually. You have the rapid acting, short acting. Short acting is regular insulin, and this is created by recombinant DNA technology, which means that we inject human insulin gene into a DNA structure of E. coli, and basically E. coli will produce recombinant form of human insulin. So it just produces over and over again. It's kind of like we've taken the E. coli hostage, and it just produces that human insulin for us over and over again. It is unaltered insulin, so it is the exact form that ours is. All other forms of insulin are synthetic alterations. to their chemical structure that allow or alter their onset or duration of action. So the rapid acting, the intermediate acting, and the long acting are all synthetic alterations to the regular insulin. Now, regular insulin is special in that it is the only one that can be given IM or IV. IM is not readily used all that much because it has a fast onset of action and can really cause hypoglycemia, so they don't generally use it. But it is the only one that can be used that way. Intermediate acting, these are your cloudy ones. These are the only ones that are cloudy, so make sure you know that. The long-acting insulins, what's interesting about these is that they form insulin crystals by adding protamine sulfate to it. So they create these chemical conditions which allow for crystals to form, and then they're given sub-Q, and the crystals are inside the skin, and they are slowly absorbed over 24 hours, so that makes them long-acting. What's great about the long-acting ones is that they provide constant level of insulin. They sometimes are given every 12 hours, sometimes they're given every day, it just depends. We have fixed combination insulins, which allow for less injections. Usually it's a rapid onset or fast acting and intermediate duration of action insulin. You give within 15 minutes of a meal because that provides for the rapid acting, and then it will last the time period of an intermediate acting. So it contains two different insulins, so you're going to have two peaks. You have one rapid acting or short acting insulin, and that's going to be for the time just after the meals and right before, and that would be a rapid acting peak of 1 to 2 hours. And then you have one intermediate acting insulin, which is to provide for the time between meals. So you have a peak at 4 to 8 hours, which should cover the second meal and provide a steady state of insulin. There's your different kinds of or forms of combinations that you see there. The first one, the Humulin 70/30, what that means is that it's isophane insulin, which is intermediate, and then the slash is the regular acting human insulin. Okay, so the first one is the intermediate acting. The second one, the 30% or the 25% or the 50%, is the rapid acting or the regular insulin. So this chart is under your resources. It's called an insulin comparison chart. I want you to use this to study. These are the numbers that we're going to be using for when action times, onset, peaks, and durations. So make sure you look at this, make sure you're studying this, because you absolutely need to know this. So we need to always know the onset of insulin because we need to make sure that they're eating, okay, within that time period. So they have to be eating within the onset of time, okay? So if we're going to be giving rapid acting, we know that the onset of a rapid acting insulin is 15 to 30 minutes. So we need to make sure we give a meal within 15 minutes of giving that insulin, okay? Now when we look down at the onset of action of insulin, we see that. Then we see the short acting is a little bit longer. It's about 30 minutes of onset, okay? And it has a peak that can last a little bit longer, okay? And the duration of action is a little bit longer with our rapid acting. And you see as we go to the intermediate acting, the onset's a little bit longer, peak's a little bit longer, and the duration of action's longer. And then again with the long acting. Now, in the combinations, remember there's one injection, but you're going to have an onset of action is going to be whatever your rapid or your regular insulin onset of action is. Okay? So it's going to be quick. And then it's going to have 2 peak times. So its first peak is going to be when the regular insulin is peaking, or rapid insulin is peaking. And then the second peak is when it is going to be when the intermediate insulin would be peaking. And then the duration of action is how long the intermediate insulin action would be, duration of action would be. So that's how that works. So make sure you look over that. Make sure you know that. You're definitely going to be asked about that. So with insulin, you can have a sliding scale or you can have a basal bolus. With sliding scale, it's used to correct blood glucose levels. So it's more of a reactive kind of insulin thing, which is the disadvantage to it. So you're going to have to check glucose levels before meals and at bedtime. And basically, according to what the glucose level is, you give a certain amount of units. Okay? So if patients are on TPN, if they're on enteral tube feedings, we're going to be checking these every 6 hours because they're at increased risk for glucose issues. So they're going to be on sliding scales. We're going to give sub-Q regular or rapid acting insulin because this is if they have a high glucose, so we want to bring it down as soon as we can. That's why we're going to use just rapid or regular acting insulin. Again, the disadvantage is that it's more reactive versus proactive. With basal bolus, the attempt is to mimic the pancreas. So you have a long-acting insulin to keep the insulin kind of at a constant level, a steady state of insulin. And then a bolus insulin, which would be a rapid-acting insulin, which is going to mimic the burst of insulin released by the pancreas. So you're going to still have meal correction doses when we would normally see an increase in glucose, okay? So we'll still need to check the glucose, after meals to check how much additional insulin they're going to need. So your glucose is monitored frequently. When we would normally expect to see the spikes in the glucose levels, that's when we need to check it. It's not really good for a patient that's NPO because there's an increased risk for hypoglycemia with the basal bolus because we've given them a steady state of insulin that's always in their system. So if a patient's NPO, they're more than likely going to be on a sliding scale. So oral anti-diabetic drugs, the guidelines. So if a patient is a new onset diabetic, type 2, the first step is lifestyle interventions. They want them to improve their diet, weight loss, and exercise. After 2 to 3 months, if they're still having high glucose levels, then we're going to add metformin. If they're not meeting the A1C goals, which we said was less than 7, basically 6.5 or greater. Step 3, we've already added the metformin. They're still not meeting A1C goals. Then after 3 to 6 months, we're going to do the maximum dose of metformin. And then we're going to add one of these 2 medications. We're either going to add a GLP-1 agonist or we're going to add insulin to the regimen to help control that. So let's talk about metformin. The mechanism of action is it increases the glucose uptake and use by the liver, basically, and the muscles. So it decreases glucose production by the liver, so it's not going to be producing as much, not doing the gluconeogenesis. Increases glucose uptake and use by the muscles. It decreases intestinal absorption of glucose, and it improves the insulin receptor sensitivity. So basically, it really is just increasing the glucose and uptake and use. Adverse effects is that it can cause lactic acidosis. The signs and symptoms are listed there. Make sure you know these, okay? It can cause GI, nausea, and vomiting. which will eventually subside with use if they can tolerate it long enough to get those symptoms to go away. It does decrease their B12 and folic acid absorption because it affects the absorption of glucose. So a patient may need supplementation of B12 and folic acid. It's something they need to be monitoring to see if they're deficient. Contraindications, renal dysfunction, because metformin is excreted via the kidneys. So if there's renal dysfunction, then metformin can accumulate, and that would increase the risk of lactic acidosis. Another contraindication is alcohol abuse. Alcohol increases the risk of lactic acidosis as well. And severe infection, shock, or hypoxia are also contraindications. So nursing considerations with metformin. We want to monitor creatinine levels because creatinine levels help us to know how the kidneys are doing, right? Creatinine levels must be below 1.4 in order for us to use metformin. We also must stop metformin 24 to 48 hours before they're going to undergo any kind of IV contrast. And they can't use metformin for 48 hours after using IV contrast. In fact, IV contrast is so hard on the kidneys, so that's why we can't use them together. We also want to check the creatinine levels before we restart the metformin, just to make sure that the kidneys have not suffered damage from the IV contrast and it's gotten all out of their system before we start the metformin back. So we monitor for adverse effects, signs and symptoms of GI symptoms, signs and symptoms of lactic acidosis, and of hypoglycemia. May need to give supplements if B12 or folic acid deficiency. With patient teaching, GI symptoms, let them know that the GI symptoms will usually subside with use if they can tolerate it. They also need to know the signs and symptoms of lactic acid, and that if they see them, they need to withhold med and then call their provider. They need to avoid alcohol because this can increase the risk of lactic acidosis. They need to log their glucose levels. They need to note any patterns, certain foods or infections that increase their glucose. They need to continue their diet and exercise regimen as well. Now we're talking about sulfonylureas. These are the glipizide, glyburide, and glimepiride. Mechanism of action, they function like the body does to meals. So they stimulate the release of insulin from the pancreas. So basically they just stimulate the beta cells. So we must have functional beta cells. The beta cells must still be in good working order. Adverse effects can cause hypoglycemia because we're increasing insulin right in the blood. So we need to monitor glucose levels. It can cause weight gain, so that we need to make sure that they're doing exercise and proper diet. Contraindications is that it should not be used with insulin. NPO or decreased caloric intake or advanced age, because this can increase their chances of hypoglycemia. And then alcohol. It actually causes an awful nausea, vomiting, increased heart rate, palpitations, reaction if they drink alcohol with sulfonylureas. So interactions, alcohol, we already talked about that. Intense nausea, vomiting, flushing, and palpitations. NSAIDs, sulfonamide antibiotics, because there can be a cross allergic reaction if they're with that. Cimetidine, which is Tagamet, and ranitidine, which is Zantac. Those are H2 blockers. A lot of patients are on those. They can have interactions. Beta blockers, we talked about this. They can mask the signs and symptoms of hypoglycemia because beta blockers, hypoglycemia causes tachycardia, tremors, palpitations, and diaphoresis. And the beta blockers will actually prevent the tachycardia and the tremors. So patients should be closely monitoring their glucose levels if they are on beta blockers, because they cannot count on recognizing the signs and symptoms of hypoglycemia. Beta blockers also block insulin release by beta cells, which will decrease the effectiveness of the medication. So nursing considerations: potential from cross-allergy to the sulfonamide products. Patient teaching: we want them to take it 30 minutes before breakfast. It's given every day. They need to exercise and proper diet to decrease their risk for weight gain. They must always have a source of glucose readily available at all times for episodes of hypoglycemia. The glinides, the mechanism of these are structurally different than sulfonylureas, but similar mechanism of action. They stimulate the release of insulin from the pancreas. So again, we must have functional beta cells. Adverse effects, same as sulfonylureas. They're going to potentially cause hypoglycemia and weight gain. Contraindications are sulfonylureas. It would have an additive effect. It would be like ODing on or overdosing on sulfonylureas, and would really dump a lot of insulin into the blood. Interactions is gemfibrozil, which is a cholesterol med. It will decrease the metabolism of the glinides, which would increase the amount of glinide that stays in the bloodstream. Nursing considerations: we want to monitor glucose levels, right? Patient teaching: take before each meal within 30 minutes because it has a short time of action. Glitazones, mechanism of action: they are insulin sensitizing drugs. So they increase the sensitivity of insulin receptors, which will help decrease insulin resistance. These two help decrease serum glucose, because they stimulate glucose uptake and storage in the liver, which will decrease the serum glucose, and they inhibit glucose production in the liver. So both of those are going to decrease serum glucose. Adverse effects: edema. They retain fluids, which can cause fluid overload, which causes edema, and which can potentially cause heart failure. So we want to monitor weight, because that helps us to monitor edema. And we want to monitor for signs and symptoms of heart failure. Increased LDL levels, so we want to monitor LDL levels, and it can cause hepatotoxicity. So, which means it puts a lot of stress on the liver. So we will want to monitor baseline liver function tests and then monitor them every so often. So what are our liver function tests? They're the AST and ALT, right? Contraindications: severe heart failure, because we're already putting stress, we're putting extra fluid in there. So if they already have heart failure, it'll put further stress on the heart. History of any bladder cancer, and liver disease, because this medication puts stress on the heart already, on the liver already. So if they already have liver disease, we don't want to be using it. Interactions: insulin can make the edema worse. Atorvastatin is a cholesterol-lowering medication, and ketonazole, which is an antifungal, those both increase the level of glitazones in the blood. Rifampin, which is the antibiotic used for TB, and cimetidine, which is the H2 blocker, decrease the level of glitazones in the body. So this one increases the levels, and this one's going to decrease levels. Nursing considerations: we want to monitor weight because we're checking for edema. We monitor for signs and symptoms of heart failure. We monitor liver function, and LDL levels because of the hepatotoxicity and then the signs of the LDL labs. Patient teaching may take months before they start to see an improvement, so they need to know that. There's a really slow onset of action. Maximum activity may not be evident for several months. They take this once a day. They need to be monitoring for signs and symptoms of heart failure. This would include dyspnea, shortness of breath, edema. They need to monitor for signs and symptoms of hepatotoxicity. This would be like jaundice or dark urine. So alpha glucosidase inhibitors, these reversibly inhibit the absorption of glucose in the small intestine. So the mechanism of action, it decreases glucose elevation after meals because it's preventing or it's inhibiting the absorption of glucose that we take in our meals. So it slows the glucose absorption and digestion in the small intestine, which helps prevent the spike in the glucose after eating. Adverse effects, GI, you can have cramping, distension, diarrhea, gas. These are signs and symptoms that you always have when you have trouble digesting things. Okay, we've affected the absorption and digestion. It's going to cause those GI issues. It can cause anemia because it can decrease the iron absorption. So we're going to need to monitor our hemoglobin and hematocrit and our iron levels. It can cause hepatotoxicity if it is used long term. So we're going to do a baseline liver function test and then continuing to monitor it every now and then. We will stop the medication if elevation does occur, and it will go back to normal after we stop the medication. So contraindications, if they already have GI disorders, we don't want to use it. This would be like irritable bowel syndrome, Crohn's, ulcerative colitis, basically because we're manipulating the small intestines. So we don't want to cause, and if they already have a problem, we don't want to cause any more of a problem. Interactions, sulfonylureas and insulin will increase the risk of hypoglycemia. So we want to monitor glucose. Metformin can increase the GI issues and increase the risk of hypoglycemia. Nursing considerations, we want to monitor hemoglobin and iron levels because of the potential for anemia. So we're going to be checking for iron deficiency. Monitor GI symptoms. If it's intolerable to the patient, then they won't take it. So we need to make sure that they're able to tolerate the GI symptoms. Patient teaching, they need to take it with first bite because it helped prevent the absorption and digestion of glucose, so it needs to be taken with meals, okay, to prevent that spike in glucose after eating. So our DPP-IV inhibitors, the gliptins, their mechanism of action, it delays the breakdown of incretin hormones. Now, incretin hormones are released in response to eating, okay? So it's in response to an increase in glucose. So this delays the breakdown of incretin hormones. So thus it increases the level of incretin hormones available to stimulate the pancreas. So the incretin hormones are released in response to eating. The incretins are released by the small intestine when we eat, basically to tell the pancreas to release insulin and to decrease glucagon secretion. So it reduces fasting and postprandial glucose levels from being high. Patient teaching, they need to take it once a day. Now we are moving to sub-Q anti-diabetic drugs that are not insulin, okay? Before we were talking about PO meds, now we're talking about sub-Q meds, okay? Now, if you remember, we just talked about the gliptins delay the breakdown of incretin hormones. This one actually mimics the incretin hormone, so it acts like it. So they have the same mechanism of action. The incretins are released by the small intestine when we eat to tell the pancreas to increase the release of insulin. It decreases the secretion of glucagon, and it also delays gastric emptying, which will delay the absorption of PO medications, which will affect other things. So it also reduces fasting and postprandial glucose. Adverse effects, GI, because it has nausea, vomiting, and diarrhea. We need to let the patients know. They need to notify their prescriber if the GI symptoms are intolerable, if they are unable to take their medication because of the horrible adverse effects. It can also cause pancreatitis, which will cause severe intolerable abdominal pain, left upper quadrant pain. If they experience this pain, they need to stop the medication and they need to notify their provider. Contraindications would be renal failure, ulcerative colitis, history of pancreatitis because it would make it 10 times worse, and they need to use caution in patients with thyroid disease, older patients, and patients with renal impairment. So interactions, we talked about that it delays gastric emptying, so this is going to delay absorption of PO medications. So you want to administer PO meds 1 hour before the sub-Q, okay? Sulfonylureas, they actually increase the risk of hypoglycemia. So what you would do is just give a lower dose of sulfonylurea. Nursing considerations, it's a sub-Q that goes in the thigh, the abdomen, or the upper arm. With patient teachings, they need to know that the sub-Q is given 60 minutes prior to a meal. They administer it in the morning and then the evening meal, 60 minutes prior to the morning and then the evening meal. There is a once-a-week formula also available, so it just really is dependent on what med they're using. If it's severe intolerable abdominal pain, they need to stop because it's probably pancreatitis and call their provider. With the medication, they need to know it's supplied in a pre-filled syringe that they need to keep in the refrigerator. They administer it sub-Q on their schedule, which is depending on what medication it is, and they have to discard it after 30 days. The pre-filled syringe won't stay good for longer than that. Effectiveness, before meals, the glucose should be 90 to 130. After meals, it should be less than 180. And their hemoglobin A1C should stay below 7%. Amylin agonists, these are mimetics, which means they mimic something. So amylin is secreted by the beta cell along with insulin in response to food. So it's designed to decrease the spike in glucose after eating. The mechanism of action, it mimics the action of amylin, which is released by the beta cell with insulin to help insulin basically do its job. So it slows gastric emptying, which increases satiety. So you have decreased intake, and it slows absorption of glucose by the small intestines. It suppresses glucagon secretion, so the liver won't convert glycogen into glucose. Adverse effects, it can cause nausea, but you can always decrease the dose if the patient is unable to tolerate it. It can cause a reaction at the injection site, but that's self-limiting. It will go away. Contraindications, renal failure, gastroparesis, which is delayed gastric emptying because it already causes a delay. So we don't want to delay in gastric emptying. So if they're already having a delay in gastric emptying, then we don't want that. If they are on meds that delay GI motility, like opiates, or delay food absorption, like those alpha glucosidase inhibitors, then it's contraindicated. We want to use caution with thyroid disease, osteoporosis, and alcohol abuse. Interactions: insulin, want to decrease insulin dose by 50% if you use insulin with it because it can cause hypoglycemia. Delays absorption of drugs taken at the same time related to that delayed gastric emptying. Nursing considerations: sub-Q, it's going to be in the thigh or the abdomen. Patient teaching, they need to administer it before meals and it's sub-Q. They need to administer other drugs at least an hour before or 2 hours after. Medication storage, we want to keep unopened vials in the refrigerator. Once it's open, it can stay at room temperature for 28 days. Keep vials out of direct sunlight and do not mix in the same syringe with insulin. You should not be mixing anything with insulin ever. So sodium glucose cotransporter 2 inhibitors. These are actually used in type 1 along with insulin. Glucose is absorbed in the renal tubules via the SGLT2. So the mechanism of action is it inhibits the reabsorption of glucose in the renal tubules. So this results in glucoseuria, right? So your adverse effects are due to the increased glucose in the urine. So you're going to have genital yeast infections, you're going to have UTIs, polyuria, because the increased glucose in the renal tubules pulls more fluid in, which causes increased urinary output. This polyuria can result in hypotension from dehydration and dizziness, especially if the patient's already on a diuretic. Contraindications: kidney dysfunction, because we are manipulating the kidneys. So if they already have some kind of kidney dysfunction, we don't want to use it. Interactions: rifampin, which is the antibiotic used for TB, phenytoin, and phenobarbital, which are anti-seizure meds. These will decrease the effects of SGLT2 inhibitors. Thiazide and loop diuretics will increase the effects. So you want to monitor for dehydration and hypotension if taken together. Nursing considerations: you want to monitor for hypotension. Patient teaching: they want to rise slowly from sitting because of the risk of hypotension. They need to report any dizziness to the provider. They need to take it once a day before breakfast. There is an FDA warning risk of ketoacidosis with this medication. I talk about glucose elevating drugs. We've been talking about meds that decrease our glucose, so now we're switching. Make sure you know the signs and symptoms of hypoglycemia. You have your early signs and your late signs there. They're oral forms of concentrated glucose, and you only give these in an alert patient. The buccal tablets, which mean they go between the gum and the cheek, and gel forms. You do not ever use table sugar because it doesn't produce a rapid enough effect. It has to be broken down in order to be effective, so it would take too long to create an effect. IV glucose, which would be D50. Use this in an unconscious patient with IV access. Patient that's unconscious that doesn't have IV access, you can use sub-Q glucose, which is glucagon. So glucagon, remember, tells the liver to break down glycogen into glucose. So glycogen increases blood glucose levels. It stimulates the breakdown of glycogen into glucose by the liver, decreases glycogen synthesis by the liver, so it stays in glucose form. Adverse effects is GI distress, nausea, and vomiting. Contraindications would be hypoglycemia from starvation because there are no stores to stimulate. Okay. Caution with cardiovascular disease. Nursing considerations: you can administer it sub-Q, IM, or IV. You want to make sure you always turn the patients before you administer it because it can cause vomiting, massive amounts of vomiting. So you want to prevent aspiration of their emesis. So turn them before you administer them. it. You want to give food as soon as they're conscious and able to swallow. This will help build up the depleted stores from the glucagon. And patient teaching, they should always have a source of glucose and a glucagon kit at all times. Anti-diabetic medication considerations and patient teaching. Nursing considerations, if they're NPO, may still get an oral anti-diabetic drug if they're on D5 IV fluids, so always check with their prescriber. Diabetics are at an increased risk for hyperglycemia during stress. That can be emotional stress or physical stress. So if you'll notice, whenever you're in a clinical setting, just being in the hospital is enough to stress the body and will increase glucose levels, even in a patient that doesn't have diabetes. Patient teaching, signs and symptoms of hypoglycemia and hyperglycemia. They should know these. You should know those. Avoid smoking and drinking with oral anti-diabetic meds. Ginseng and garlic may increase hypoglycemic effects of oral anti-diabetic meds. So they should know that. If they go to Olive Garden, make sure they're having enough. I guess they're eating pasta, so it may even out with that. Consistent carbs and exercise plan. They should exercise 30 minutes every day. This will help prevent fluctuations in glucose. And they need to check their glucose before and after they exercise.